Fantastic. Well, good afternoon if you are in Palestine, and I hope you're having a great day wherever you are. Welcome to the sixth session, which is on children and adolescents. And thank you to the moderator and to the presenters of the previous session for finishing perfectly on time. So we have two presentations in this session, and I'm alerted that one of our speakers may not be able to join us. Nevertheless, I encourage you to please put forward your questions that they may be conveyed to her in the session recordings, and she might be able to communicate with you. So the first session is on the risk factors of hearing impairment among infants and toddlers in the Gaza Governorates. It's a case control study, and this is a study by Dr. ARanda Zaqqout. So ARanda has a bachelor degree in medicine and a master's degree in epidemiology from Qatar University. She is currently the Field Family Health Officer at UNRWA Gaza, responsible for maternal and child health services provided to Palestinian refugees in the Gaza Strip, and she's also responsible for school health services at UNRWA schools. She is a member of different national committees related to maternal and child health, and her research was used to develop a pilot project to conduct newborn hearing screening in UNRWA and the Ministry of Health primary health care centers. So if we can have Dr. ARanda Zaqqout's presentation, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. ARanda Zaqqout. I had a bachelor degree in medicine from Al-Quds University. Then I had a master's degree in epidemiology from Al-Quds University also. I'm working as a field family health officer at UNRWA Gaza field office. I'm responsible about the maternal child health care services provided to Palestinian refugees in addition to school health. My presentation today is about the risk factor of hearing impairment in Gaza Governorate in children 0 to 3, a case control study. I will share with you now my presentation. As I said, the aim of the study is to explore the risk factor of hearing impairment among children below 3 years old. The study is looking ultimately to provide healthcare provider with recommendation that might help in combating hearing impairment through identifying the risk group and targeting them by prevention and screening program, especially that we don't have a universal hearing screening for this newborn. This is my framework. You can see here that I try to cover all the possible risk factors that could affect the occurrence of hearing impairment. You can see here that I try to study the family history of hearing impairments, factors related to maternal health and diseases like antenatal period, if she has a chronic disease, if there is infection of the mother, any medication and supplementation. I also studied risk factor related to fetal and childhood factors like delivery complication, if the child was premature, admitted to an ICU, did he need mechanical ventilation, and so on. I also studied the health service provision like access, follow-up, did the mother have preconception care, antenatal care, postnatal, and so on. I also studied the environmental condition like hazardous material, pollution, heavy metals, noise, trauma, smoking. I also studied factors related to socioeconomic status like maternal age, father age, income, literacy, occupation, and housing condition. The methodology. It was a case control study to population. Cases are children who had diagnosed to have moderate and severe and profound neurosensory hearing impairments. Controls are children identified to are free from any kinds of hearing impairment, as proved by screening conducted by Atfaluna Society for Deaf Children. This is a non-profit organization that deal with those children, providing different services, and they have list names of those children either who have hearing impairments or who are free. Cases were randomly selected from Atfaluna Controls were selected from Ministry of Health, UNRWA, NGOs, and proven to be free from any kind of hearing loss. Each case was matched by one control from the same age group, plus minus 2 months. Sampling, I used the EBInfo to calculate the sample size. The sample size, according to EBInfo, was 152, but I decided to increase to 170. The instrument was a self-constructed questionnaire. I reviewed the literature. I had also reviewed some questionnaire related to other types of disabilities. The questionnaire was reviewed by 9 experts. I had conducted a pilot study. Then me and 4 trained data collectors collected the data through to face-to-face interview conducted at household, finding and analysis. Being a refugee increased the risk by 1.6, and residing in rural or camps increased the risk by 8.8. Economic condition, father unemployment was not statistically significant, but mother unemployment increased the risk by 3.9, and receiving social assistance increased the risk by 2.3. Family history, being from the same family or consanguinity increased the risk by 3.8, and families with positive family history like first degree father, mother, brother, and sister increased the risk by 8.8. Maternal factors, mother who been diagnosed to have pregnancy-induced hypertension were increased, increased to have a baby with hearing impairments by 2.4-fold. And this could be, linked to prematurity condition, as some cases of BIH had to have babies born premature. High-grade fever increased the risk by 5.2. History of trauma during pregnancy increased the risk by 2.9, and this also could also relate to prematurity. History of imaging increased by 4-fold. Related to other maternal factors, women who failed to have folic acid for 3 months and more during the preconception care were at a greater risk of having children with hearing impairment. Having folic acid in the first trimester decreased the risk. Having iron supplement during pregnancy also decreased the risk by 55.4%. Women who were delivered normally had lower risk by 48.3 compared with those with assisted vaginally or CS delivery. All these factors related to prematurity, which increased the risk by 3.4, and low birth weight also increased the risk by 5.8. The most important here risk factor related to fetal and childhood factor was admission to an ICU and the need of mechanical ventilation, which increased the risk by 2.9 folds. It makes no difference to have a jaundice, but if it was pathological jaundice, it increased the risk. Children with congenital anomalies also have increased the risk by 2.4 folds. And mainly we focus on congenital anomalies related, to ear, nose, and face. Fetal and childhood factors. In my study, history of serious illness, which require hospital admission, increased the risk by 2.1. Meningitis in my study showed no significant difference. Recurrent otitis media increased the risk by 7.4. The use of ototoxic medication increased the risk. Exclusive breastfeeding decreased the risk by 43.6. Health service provision, receiving antenatal care and early registration decreased the risk by 88% and 65.9% respectively. Exposure to loud noise increased the risk by 2.4. Exposure to very high noise, even once, increased the risk by 1.9 folds. And mainly this high noise was related to bombing and explosions. This is the summary model, which explains more than 42% of the differences between cases and control. Families who have receiving social assistance and have positive family history, interfamilial marriage, all these increase the risk of hearing impairment. Using folic acid and iron decrease the risk. Being low premature and have recurrent otitis media increase the risk. Living nearby trash container also increase the risk in all this regression model, and this could be reflected or reflects, the bad socioeconomic condition and poverty. My recommendation is that in the absence of universal screening, at least we can target those people, children who are at risk, like premature, low birth infant, infant with positive family history, children who suffer from recurrent otitis media, and infant and children from very poor families. The recommendation of this study was adopted by Red Crescent organization, who are now conducting a pilot study for hearing screening in Gaza Governorate, in UNRWA and Ministry of Health health centers, and they are now targeting all people, focusing on those with risk factor. This study also, one of the recommendation is to introduce and reinforce preconception care, which include counseling and provision of appropriate supplementation like folic acid. And preconception care was implemented or introduced in UNRWA in 2009. I think 2 years ago it was introduced in Ministry of Health and other NGOs. It's very important and should be implemented in all sectors. More efforts are needed to improve the quality of antenatal care, especially early registration, which is an important indicators that reflect the quality of antenatal care in order to identify any risk factor and act early. During pregnancy, the maternal use of medication and exposure to imaging should be very restricted and under direct supervision of medical officer, doctor, and so on. Safety measures are needed during and after pregnancy to protect children from injury and loud noise, promote safe delivery practice to reduce, complications like asphyxia. Communicable disease like otitis media is identified as a risk factor, should be, appropriately diagnosed and treated and follow up. Recommendation for a new area of research. We need a national survey to be conducted here in Palestine to identify the prevalence of hearing impairment. We also need a larger research to get more deep in the risk factor of hearing impairment with larger maybe sample and so on. A research is needed to define the level of noise that could cause hearing impairment in children in order to set a preventive measure. A research is needed to study the effect of bombing and explosion in hearing ability in children in Gaza. A research is needed to determine the type of inheritance. We don't know what is the type of inheritance here in Gaza or Palestine of congenital hearing impairment in Gaza Governorate, again to set a preventive measure like counseling and so on in the pre-marriage and the pre-conception care. Thank you, and I hope it was a useful research.
Thank you very much. I'm sorry I'm having problems turning on my camera again. Shiraz, could you confirm if Dr. ARanda Zaqqout is still not with us?
She's not with us. No, she's not, unfortunately.
Okay, no problem. Well, we're going to move on for now to the next presentation, but may I ask the audience to please prepare your questions and your comments on the study. I think hearing impairment is very important and it has long-term, developmental implications. I think it would be useful to give Dr. Zaqqout some feedback about her model and the variables that were used in the model to tighten some of the confidence intervals and to actually probably sharpen the recommendations and the focus on some and not all of the variables. So if any of the group or the audience now are interested in this, I'd ask you to please make your notes, and you can share them either at the end of this session or we can communicate them to Dr. Randa. What I'd like to do now is to move on to the next presentation, which is entitled Fieldwork Opportunities and Challenges in Palestinian Refugee Camps in the West Bank of Palestine and Jordan, Lessons Learned from the Palestinian Adolescents Reproductive Health Study, a very interesting study that I've been following through social media. And it's presented by a dear colleague, Rula Ghandour. Rula is an academic researcher at the Institute of Community and Public Health at Birzeit University, and she has been since 2008. She has a bachelor's degree in pharmacy and a master in public health degree. Her research experience includes pharmacoepidemiology, health economics, and non-communicable disease epidemiology. Currently, her focus includes women's and reproductive health, in addition to research methods and data analysis techniques. Rula is working right now on her PhD research addressing Palestinian refugee adolescents' menstrual health at the University of Oslo. Today, she's presenting some insights from her fieldwork for the PhD, and we're looking forward to it. Please go ahead.
Hello, my name is Rula Ghandour. I am an academic researcher at the Institute of Community and Public Health at Birzeit University and a PhD student at the Institute of Health and Society at Oslo University. Today, I'll be presenting some insights from my field experience for my PhD project, which is part of a bigger ongoing project implemented by the Institute of Community and Public Health at Birzeit University. It addresses the health needs of adolescent girls living in Palestinian refugee camps in the West Bank of Palestine and Jordan. And this is the title of my presentation: Fieldwork Opportunities and Challenges in Palestinian Refugee Camps in the West Bank of Palestine and Jordan, Lessons Learned from the Palestinian Adolescents Reproductive Health Study. Because this presentation is concerned with fieldwork challenges, I will just go very brief with its main aims and objectives to save more time to discuss the main topic of the presentation. For those who are interested in more information, please contact me and I will be happy to discuss further. The general aim of the ongoing study, which is the Palestinian Adolescents Reproductive Health Study, is to understand the current health status of adolescent girls, 15 to 18 years old, living in Palestinian refugee camps in the West Bank of Palestine and Jordan. What are their main health problems and needs, and how their broader context shapes these needs and problems, and then design a contextually relevant intervention based on the findings. As I mentioned earlier, the study was conducted in the Palestinian refugee camps, which I think most of you are familiar with. These are long-lasting camps, 72 years old. People living there suffer from high levels of poverty, unemployment, crowded households, insecurity, political instability, and a wide range of social and cultural constraints, especially for adolescent girls. About the Palestinian Adolescents Reproductive Health Study, it consists of 3 phases. First, we started with a qualitative phase where we visited all refugee camps in the West Bank and Jordan. We conducted in-depth interviews and focus group discussions with adolescent girls. Also, we visited lots of local organizations and stakeholders at these camps, including camp service officers, popular committees, refugee affairs, women's centers, clinics, youth centers, CBR, and many others. This helped us understand the camp underlying conditions and facilitated the design of the other phases of the study. In the second phase, which is the focus of our presentation, we conducted a household survey with around 3,000 girls aged 15 to 18 years old from the 29 refugee camps in both countries. Data related to nutrition, menstruation, hygiene, and mental health were collected. And finally, now we are in the third phase, which is the intervention phase. Unluckily, I will not go through it because it's beyond the scope of this presentation. Highlighting more details of phase 2, which is the focus of this study, we visited the households in the 29 refugee camps in the West Bank and Jordan. Data were collected from around 1,500 girls in each country by female field workers from the local communities, and it was aimed to complete the data collection during summer holidays, where girls are expected to be at home. Of course, throughout the process of data collection, we faced lots of challenges, but mostly there were an opportunity lying somewhere around. Challenges were faced at different levels, the political, social, cultural, and economic, and started from the early planning phases. Both challenges and opportunities were many. I need hours to present them all. Of course, in this small presentation. I will try to summarize some main important points here. Let's start with the camp entry. To enter the camp, knocking the doors, asking for adolescent girls in refugee camps where the community is mostly conservative and people knows each other, this was not an easy task. Eyes were always on the field workers and what they are doing. Field workers were questioned several times about their aims and what they are doing in the camp. Worth noting here that this was more pronounced in Jordan compared to the West Bank. Luckily, we were advised ahead of time to sensitize the local community about the topic. And before starting field work, as I mentioned in phase 1 of the study, we visited all relevant organizations, committees, stakeholders in the camp and informed them about our goals. All were very cooperative and facilitated the entry of the field workers to the camps. Furthermore, most of the field workers were from the local community who were camp dwellers or familiar with working in camps. They knew the language to approach people and at one hand, and also they had all the time they had supporting documents reflecting their role. Another main challenge we faced during data collection was the random walk procedure and the camp structure. And here I'm talking about the procedure of selecting the sample. Simply, it means selecting a random point in the camp, then include all the households to the right. To ensure randomness in selecting the sample, field workers needed to follow the procedure very precisely. Of course, the best way of doing so is to have a map. And although maps do exist, still field workers find it hard to follow the maps, especially with camps with complicated structure. This consumed lots of the research team efforts and time as supervisors of field work, especially that we've started all camps in Jordan at the same time. So lessons learned from this, please, if you are doing this in any place, don't start all research places at the same time, or at least have a local supervisor in each place. But to be honest, some field workers were really creative in this instance. They managed to build their own maps, and they used to send us out their drawings every day. This is one example of these drawings. Crowded households and confidentiality. Of course, this is a main issue. And the problem of having small households with limited indoor spaces makes it even harder. Sometimes there were more than one girl at the household eligible to participate, and they wanted to stay and listen to each other. Sometimes the mother insisted to stay and tend to answer the questions on behalf of her daughter. Some girls used to look at their mothers as if she's making sure she will agree to her answers. One of the techniques we've approached to minimize these biases, especially with questions that is thought to be sensitive, we asked the girls to read and click on the correct answer as we used electronic tablets in data collection. Another technique, especially in Jordan, which actually worked very well, where we had two field workers visited the households. One of the field workers tended to talk to the mother, grasping her attention from the questionnaire. Another challenge we faced during our data collection was the resistance to finger prick blood tests. Maybe I did not mention this before, but one of the aims of our study was to measure anemia level using a simple finger prick blood test and to report the results directly to girls and their caregivers or parents. Of course, we've got all the ethical approval in this instance. However, still resistance exists to such tests. Many people were afraid of contamination or having harmful effects. Of course, in this instance, we couldn't help. It's their choice. Worth noting that this was more pronounced in the West Bank compared to Jordan. Finally, for the sake of time, I want to reflect on the unstable political situation. Of course, this applies more to the West Bank compared to Jordan. Because of the road closures and unpredictable events and the fear from working late during the day for safety reasons, delays occurs, and we spent around double the expected time in data collection. These are some of what we faced during our fieldwork. And of course, this is just the tip of the iceberg. Much more still exists. For example, using electronic tablets in data collection and the challenge of transferring it to Jordan and all the technical things related to it. Managing and supervising large numbers of field workers at the same time. Monitoring collected data and timely audit, having data collection conducted in 2 different countries, one of which we are not familiar with, and many others. So, to sum up, the main take-home message is that when conducting research in Palestinian refugee camps, first, you need to know the camp well. Each camp is unique and has its own characteristics that need to be taken into consideration in planning. Second, the local organizations at each camp is very important, starting from UNRWA to the popular committees in the West Bank, the refugee affairs departments in Jordan, service committees, women's centers, community-based rehabilitation centers, and many others. And I want to take this chance to thank them all for their great support in our work. And please forgive me if I missed anyone. I want also to stress again on how useful it was when we had field workers from the camps. So if you're planning to conduct research in refugee camps, consider having someone who knows the camp very well. Finally, and most importantly, always develop contingency plans, including extra time, personnel, and resources to overcome unforeseen circumstances that is usually many. And thank you.
Thank you very much, Rula, and I see that you're with us. Thank you for this very heartfelt presentation. the challenges of field work. But I think it is a very important discussion. So many people in this group conduct household surveys and studies in refugee camps, and I think what you talk about is very salient to a lot of people. I want to start by looking at some of the comments and bringing them to you, and then I'll try to sneak in my questions in the meantime. Just a second, please. So we have a comment saying this is a very impressive example of shoe leather epidemiology. That's actually the phrase I was looking for, shoe leather epidemiology. Wearing out the soles of your shoes, not the seat of your pants. Also the crucial importance of working with local people, which is the key to high response rates. So thank you, Graham, for this important reminder. Until we get other questions, Rula, can I ask you about your sample? What type of sample were you going for? Because I think that's one of the earliest challenges you talked about, is actually knocking on doors and locating people and so on. What type of sampling design were you going for?
Yeah, well, we've started thinking of a random sample to represent all the refugee camps in the West Bank and Jordan. Of course, we've went through several stages thinking of this until we've reached to the final decision. We had a stratified random sample, including all camps in the West Bank and Jordan, the 29, and we've considered the camp as the strata. The reason for doing this is that from the first one, when we just started exploring the camps and trying to understand their structural characteristics, we found that each camp is unique, each camp is different. So thinking of a cluster sample, having some camps to be included in the study was not, we've thought about doing this, but we thought that it will not be applicable because we were so confused about deciding what are the clusters, which camps we should include. Then we've decided to include all camps, somehow proportional to size. So we have all the sample size, the population size from all camps, and we had a stratified random sample that is proportional to size.
Within the camp, so the camp
Yes.
is the stratum, and then within the camp, within each camp, how did you go about doing sampling?
You mean the technique of sampling or the type of sample?
The design of the sample. So within the camp?
Yes, within each camp, the general design of the sample, I'm not sure if I got your question clearly, but the general design of the sample, it's a stratified random sample where each camp is the strata. In each camp, we have a sample size. Of course, we've calculated the sample size based on some parameters we have, and we've ended up having like 2,050 participants from each country. We've calculated the sample size for each country alone. And it was a random size the calculation, we followed the random sample size equation. And then we've corrected for the design effect. And within each camp, the sample was proportional to the general sample size. So we had divided the camps based on its population size. And within each camp, we took a proportion. And then we divided the sample based on this proportion. And within each camp, to have the random sample, we've adapted what's called the random walk technique, because we were not able to get the list of all people living within each camp, especially that there were no updated lists to select from them. And also another way was we thought of including the maps and try to draw the roads on them and try to have a random sample from the households and try to work and select the sample. But also this was very hard in Jordan. In the West Bank, it was a little bit easier because we had updated maps from the Palestinian Central Bureau of Statistics. In Jordan, there were maps, but it was a little bit confusing and complicated, and it was very hard to get them. So we've consulted with the Palestinian Central Bureau of Statistics, and we were advised to take this random walk procedure, which is just selecting a random point from somewhere in the camp, and then start walking to the right, taking each household to the right. And when we reach a dead end, we will select another random sample and start again. The random points, again, luckily in the West Bank, we have a list of random points from all refugee camps that we were able to get from the Palestinian Central Bureau of Statistics. And we used them to select random points for the field workers to start with. In Jordan, we've created a way. So in the training of the field workers who were mainly camp dwellers, so during the training, we've asked them to write down all the main points that are well known within each camp. And then we mix them up and use them as a list for a random points.
Okay, thank you very much, Rula. Thank you for this. So we have a question from Hanan Abdulrahim. Hanan, go ahead, please.
Hi guys. It's really nice to be here again among the elite of the elite. Thank you so much for the presentations. My question is for Rula. So we are now going through a pandemic. So since your work is about data collection and you've been collecting data in the refugee camps, and I guess refugee camps, maybe through COVID, maybe they had the most and the highest difficulties in maintaining social distancing and like other COVID preventing measures. So the first question is, how did COVID affected the data collection process? And like in case you proceeded with data collection through the pandemic, how do you think it is possible and feasible to do that through COVID without getting yourself into danger, and also to have like somehow a safe data collection process? Thank you so much.
Thank you, Hanan. I'm happy to see you. This is an important question. Luckily, I was done with both qualitative and quantitative data collection before the pandemic. But the pandemic has affected our intervention because our results had highlighted the great needs for these adolescent girls for a very effective intervention that needs to be interactive, that is based on communication and activities, especially that these girls really need support in this instance. They have no opportunities or very limited opportunities in their lives. So we were thinking big of doing a very interactive, interesting intervention for them to support them in both the West Bank and Jordan. The problem was that, of course, the pandemic started and we were not able to do this. We started thinking about what to do, and we've shifted the intervention to be an online intervention, and we've worked hardly with my team, Dr. Wiam Hamoudeh and Reem Ladadwa and Dima Masoud. We worked on developing an online platform in which we will include all the findings and try to develop some material that is based on our findings from the both phases 1 and 2, the qualitative and the quantitative. And actually, this was a success story in relation to the intervention. We've developed a very nice website with very special characters that will tackle adolescent girls' needs in this phase, and it is highly based on our results. But also we faced some challenges that is related to the pandemic in implementing the intervention. So as I mentioned, it was purely online intervention. So what they needed to do is just to open the website and try to surf through the pages. And also we had weekly discussions that tackled important topics that is really a high need for them. One of the problems that we face is that everything in life for these girls had went online. So they were bored. They did not want just to go and open the website and serve it. They needed something more fun, maybe. Another thing was, and this was more pronounced in Jordan, girls mentioned that they had very specific, I don't know what you call it, the credit amount for the internet, and they use it for the online teaching, learning, so they do not have credit to go and watch the website. And I don't know, there are many others, but these are one of the main challenges. But in some aspects, there are some girls who really benefited from the website. Now we are in the process of scaling this up and trying to tackle these limitations and try to improve it in order to reach these girls. One of the things is that we've converted this website to a mobile application that they will be able to serve it offline. And one last thing, the whole content on this website was in Arabic, because one of the main limitations that was available for these girls is that to have a website that is in Arabic and they can trust.
Can I have a follow-up question, please? Just
Yes,
a quick
please,
question.
go ahead.
So since you've mentioned, thank you so much for the great efforts. I'm sure that they will benefit immensely from these interventions. But since you've mentioned that the intervention was supposed to be face-to-face, and I guess making the website will take some time, and we've been in lockdown for almost 1.5 years. So do you think that there were more challenges and more needs that emerged during the pandemic, especially that the pandemic mostly affected like economically, socially, and physically the most vulnerable people who are like in the poor, the people in as refugees and stuff. So did you do a follow-up study about what happened during the lockdown about whatever you did before?
Yeah, thank you. This is very important. And we've noticed some of the needs from our intervention. Just to follow up that our intervention, the sample for our intervention was a sub-sample from the original sample that we've selected for the survey. So we had like around 200 girls. 100 girls of them had participated in the intervention, and we were talking to them continuously. And in this instance, I think that they have, to start with, these girls has very, very limited choices in their lives. They are just focusing. They see that studying and is the way that they prove themselves through. So even this part was taken from them. So I'm sure that there are more needs, but this needs further study. Maybe I'm not sure if Reem is with us now, and she was the one who were following the girls, and she was talking to them continuously throughout the previous 6 months. I don't know if she can explore more on this, Reem.
Hi, yes, I'm here with you. I think one thing to note is that we never left the girls alone with the intervention or with the website. We were with them every step of the way. So we called them weekly. We had live meetings with them every Saturday. And they had a WhatsApp number where they were able to privately chat with one of the researchers. It was pretty much open until like 12 a.m. So from 8 a.m. to 12 a.m. And we did notice that some of that COVID presented new challenges to these girls, mainly in terms of space. So they were not able to find the personal space that they had before, mainly because the entire family was in the same house for extended amount of time. And they originally did not have private spaces, so they would have their space when the family was out, but with COVID, everyone was in the same house almost all the day. They were also pressured by school, mainly because it's online, it's a new technique, and many of them had limited access to internet due to economic status, or limited phones or laptops in the house. And one of the other challenges was stress in general. They weren't able to de-stress. I mean, they don't have any techniques to de-stress or space or support system that would help them de-stress. And it was a stressful time for everyone, but it was, I think, extra on them given that they have limited resources in almost all aspects around them.
Great,
yeah,
thanks
and
very much.
These are the stuff that come to mind now, but I'm sure there are others. But
thank you so much, Reem. Hanan, does that answer your question? Okay, great, thank you. Rula, you're getting a lot of compliments and thank yous and so on from the notes. You'll be able to read them. Can I sneak in a question about the use of tablets? I'm sorry, I know that doesn't sound exciting, but I'm very interested in survey methodology. So it's actually not a challenge. It might have presented you with logistical challenges, but it's actually, I think, a wonderful advancement in doing the surveys. And I'm glad that you're moving to it and that you're finding that it facilitates managing the survey much more so. Can I ask if you used a certain software for survey management, or what exactly were you doing with that?
Yeah. Well, this is a great question, and
it's actually not.
This is my
we'll talk about, but I find
this
it
is
very
my passion, is just working with anything electronic. So actually, I think we were among the first at the Institute who thought of just using the electronic tablets in data collection, and actually we've shifted the whole, it was not in our original proposal, but we've shifted the money from the field work to buying these tablets. And actually we've started just surfing the net, trying to find some software, and we've found some cheap one from Australia that is called Mobile Data Studio. It's really very, very useful and easy to learn and to use, and it can be connected on one server that and it can work online and offline. And luckily I had Reem, she has very good skills in electronics and software managing and all these things. So we worked together and we developed the questionnaire and the software, and actually it was a pilot. We had lots of challenges in building the software, in transferring the data, in connecting the tablets to one station, especially that we were in Jordan. We've started in Jordan, and where we do not know anything about the internet infrastructure, about how to connect, how to reach our computers remotely, and also how to train the field workers. And also we faced some problems transferring the tablets, so we had some delays in the field work, but we've managed, and now we are repeating this experience with many teams at the Institute, and Reem is doing a great job in training people in how to use it and trying to overcome the challenges that we face in doing this. But actually, it was a great experience in that we are limiting the time that we are using for data entry and data cleaning. So once the data is there, we can just start analyzing it. One of the main lessons learned in electronic data collection is that we need to monitor the data continuously. We cannot just leave the ongoing data collection, and then we will face some problems by the end. So it's good just to go every day and just to check the data and make sure that the collection is working properly and the questions is being collected properly. Another main challenge that is, I don't know where it is, if it's only in Palestine or in other places, is just with having this remote desktop access. So I know I'm here in Palestine and I can access my desktop at Oslo University very easily, and I can just serve everything there. I can use the software there and do my analysis here. It was really a very big challenge to access our local desktop where we were collecting the data. And this limited our follow-up of collecting the data. So I think we're moving forward, things are getting better each time.
Yeah, I absolutely think this is a step forward, and that's going to help you in future surveys. You're absolutely right. It helps with time for data entry, but it also helps you monitor your data in real time. You don't have to wait till the end and then discover if something is wrong, and so many other different advantages that I think you'll discover. And I really, really commend you on adding this, innovation at a time when you're dealing with many other challenges as well. So unfortunately, we have come to the end of this session. We're out of time, although I know there are so many other things that we can discuss. I do want to remind you, if you have any questions for Dr. Randa, any comments you might wish to support her with on the analysis, that you can please either leave them in the chat and they'll be sent to her, or perhaps send them through the LPHA coordination team. So I want to thank Rula and Dr. Randa in absentia, and to thank the audience for their questions. I believe we are coming on to a 15-minute break. So thank you, everyone. It was great to interact with you.
Thank you. Thank you.